Welcome to this ASN Kidney 360 podcast. I'm Sarika Salvaj, a pediatric nephrologist at the University of Minnesota. Today I'll be discussing a study published in Kidney 360 titled Socioeconomic Disparities and Preemptive Kidney Transplant Rates in Children. What are the aims and methods of the study? Kidney transplantation is the treatment of choice for children with end-stage kidney disease. Kidney transplantation is associated with survival benefits, improved growth, better neurocognitive development, and a higher quality of life compared to dialysis. Children who undergo preemptive transplants demonstrate better survival compared to those who receive pre-transplant dialysis. However, less than a quarter of children with end-stage kidney disease receive a preemptive kidney transplant in the United States. Data on the effects of socioeconomic status, or SES, on preemptive kidney transplant rates in children are sparse and conflicting. Previous studies use area-level measures of SES derived from zip codes and census data to capture individual-level SES. This approach may lead to SES misclassification. Our study aimed to examine the effects of SES on preemptive kidney transplant rates in children using an individual-level SES measure called HOUSES. HOUSES is generated by linking residential address information obtained from electronic health records to publicly available real property data. Our study included 173 Minnesota residents transplanted before the age of 18 years at a single center between 2010 and 2020. We categorized houses into quartiles, with Q1 representing low socioeconomic status and Q2 to 4 representing high socioeconomic status. We applied mixed effects multivariable logistic models to examine the effects of houses on preemptive kidney transplants in children. What are the key findings? Of the 173 participants in our study, 26.6% received a preemptive transplant. However, preemptive transplants were observed in only 13.6% of Q1 recipients compared to 31% of Q2 to 4 recipients. After adjusting for age at end-stage kidney disease, sex, donor type, insurance type, and the underlying cause of kidney disease, we observed significantly lower odds of preemptive transplants in Q1 recipients compared to Q2 to 4 recipients, with an adjusted odds ratio of 0.31 and a 95% confidence interval of 0.11 to 0.9. When the study cohort was restricted to patients who developed end-stage kidney disease after the age of 2 years, Q1 recipients remained significantly less likely to receive a preemptive kidney transplant compared to Q2 to 4 recipients, with an adjusted odds ratio of 0.28 and a 95% confidence interval of 0.09 to 0.8. What are the limitations of the study? We excluded 13 patients from our original cohort of 187 because of missing addresses. This may have introduced selection bias by omitting recipients who were most at risk of housing insecurity. The results of a single center study may not be generalizable to centers with different patient demographics. Additionally, center-specific and state-related differences in policies and resources may amplify or diminish the relevance of socioeconomic challenges. Since this was a retrospective study, we could not account for unknown confounders. Furthermore, our sample size was small. Our study participants were predominantly white, limiting our ability to determine whether race or ethnicity modified the association between houses and preemptive transplant rates. How can the results of the study be used to change clinical practice? The study highlights significant socioeconomic disparities in preemptive kidney transplants in children. The study also demonstrates the utility of houses in uncovering socioeconomic disparities and identifying children at risk of non-preemptive transplants. The findings underscore the need for targeted interventions to overcome socioeconomic barriers to timely transplantation. Early referral for transplant evaluation, timely listing, and resource allocation guided by houses may be effective strategies to mitigate disparities. Future research should include multi-center studies to examine the effects of socioeconomic status on kidney transplant access in children. The Houses Index, or a similar individual-level validated socioeconomic status measure, could be tested in the future to prompt earlier referral for those in the lower socioeconomic status quartile. It could also be used to identify patients needing more social work support earlier in the transplant process to identify community resources. Increased attention and resources for lower socioeconomic status patients may improve their access to timely transplants, setting the stage for successful long-term outcomes. Thank you for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.